hypoglycemia is a common presentation, one which is often missed. And in the case of hypoglycemia, often we may not be able to reach a diagnosis, and that may have a lot of disastrous consequences for these hypoglycemic disorders. And we'll carry forward from that perspective. Uh, you can all go and have a look at our website, where has got a lot of information, including resource in pediatric endocrinology, e-learning platform, our courses which are there, including fellowship and pediatric endocrinology programs, our grand rounds, our journal clubs, and other activities which regularly happen. Our books, which are available both online as well as the hardbound version, our mobile application, which guides
A 15-day-old male child presented to us with tonic posturing of the both limbs as well as uprolling of the eyeballs, which was lasting almost around 10 minutes, followed by unconsciousness. And the mother noticed this happening since the day 7 of life. Multiple episodes have happened and associated with some orobuccal movements. Mother had noticed that sometimes the episodes are very short lasting, resolved spontaneously, and sometimes she tried to feed the child, and child is getting improved by that. There are multiple episodes with most of the episodes even happened in the awake state. So,
Yeah.
So moving on to the negative history that we took, that there was no history of any features of like late onset neonatal sepsis, like any lethargy, poor feeding, vomiting prior to those episodes. There is no history of any maternal drug intake. We have inquired about that. There is no history of any maternal diabetes also present. There is no similar history of neonatal seizure in the family in this child. And the child given cried after birth, no history of any intrapartum or postpartum fetal perinatal asphyxia. There is no history of any umbilical catheterization insertion in this child to give some medication or IV fluid. So, moving on to the birth history of this child, the child was a term child. The birth weight was 3.5 kg, and I told that there is no history of any delayed cry during the birth. There was no significant antenatal history which will indicate that there is some fetal distress or mother having some preeclampsia. There is no breech presentation. Any forceps was used during the delivery. The child was third born child to a non-consanguineous marriage, and there was no history of any sibling death or miscarriage prior to this birth of this child. Moving on to the feeding history, for the last 7 days till the episode, the child was exclusively breastfed, and the mother has noticed a bit unusual thing, but the episodes are often frequent in the early morning hours and especially during the night times.
So just hold on. So you have a child who has an early onset of episodic movement, and which are persisting since then, or there was a gap in between.
No, it was not persisting. That there was some episodes are happening, and then there are gaps, and then again.
So what is the frequency of these episodes?
Sir, according to the mother, the some episodes are very short lasting, happens a few times in a day, but the major episodes are like twice or thrice a day maximum.
Okay. And is it associated with any decreased feeding or lethargy or any infectious illnesses?
No, it was not associated with that. But during that episodes and after those episodes, the child has lethargy. It is not taking feed well. But when the episodes are gone,
So what are the endocrine causes that you will think of in such episodic scenarios?
One could be one of the most common is the metabolic causes, like hypoglycemia could be one. Any late onset hypocalcemia could be one feature. Hypomagnesemia, any electrolyte disturbances like hyponatremia also can present like that.
So you're talking about some manifestation, but for how hyponatremia, how common will it cause seizures for such a long duration?
It will not cause it. It will have other symptoms.
Very unusual. So mostly you can say hypoglycemia or hypocalcemia.
Yes.
Now, what is the difference in terms of clinical features of a neonate who has hypoglycemia versus hypocalcemia, particularly in between the episodes?
In hypocalcemia, sir, there will be other movements like increased jitteriness, and there will be twitching will be there in between. And in during episode, the child will be otherwise healthy, sir.
So this is important. So hypoglycemia may have more persistent effect as compared to hypocalcemia, in which the child is absolutely normal from that perspective. Let's assume, as we're discussing hypoglycemia, that this is hypoglycemia. What will be the possible causes that we're looking at in the day 7 child? The first
Yes,
episode started in
day
day
7.
7, and current age is
15 days.
only 15 days.
15 days.
Okay,
Presented to us at 15 days of age.
at 15 days of age. So this is what are the most likely causes of hypoglycemia if we assume it to be hypoglycemia.
Galactosemia.
Okay, galactosemia, the usual presentation is typically around 2 to 3 weeks. Galactosemia, the problem is when you are exposed to food, your liver will be damaged and then you develop hypoglycemia. Anything else? Most common cause.
Lactose intolerance.
Lactose intolerance. So most common cause of hypoglycemia is hyperinsulinism. So that will be the first one. It's beyond 48 hours. So all that SGA, preterm, prematurity, infection, maternal, all the history that you took is relevant, but that will make it very unlikely that why will it persist beyond 48 hours. So first possibility will be hyperinsulinism. If you think of hyperinsulinism, what form of hyperinsulinism is this likely?
So it is as the child is presenting around 7 days, and before that it was completely normal. I assume that it is a KATP channel defect could be present, but a less severe variant of KATP could present.
What is against KATP channel defect here? A severe form?
The birth weight 3.5 kg.
Which is not really against. Birth weight may be, if you look at the 3.5, may actually be on the higher side for the family. The biggest thing, of course, is the course of the disease. So you have clearly mentioned that did he require hospitalization?
No, in between that
He did not require hospitalization. His episodes became normal without much intervention. So if it was really a potassium ATP channel defect, you will not be able to be normal blood sugar without giving a very high GIR. So this is saying that this is more likely to be a problem of the substrate, or do you think this is a problem of increased production of insulin? The very fact that he did not require hospitalization and seizures used to improve.
So it is because of the it can't be because of utilization. It is because of the substrate defect.
So this will make it more likely to be a substrate defect. Now, if you talk about substrate defect, basically the common causes we can think of in terms of substrate is, first of all, the first defense against hypoglycemia is glycogenolysis. Then you have gluconeogenesis. Then you have got fatty acid oxidation defect. First, of course, is frequent feeding. So if you are feeding every 2 hours, you should not develop hypoglycemia. At what gap between meal do you start having GSD presenting?
Sir, after 12 hours of fasting, sir, usually 6 to 12 hours.
6 hours. So basically, if you're feeding every 2 hours, you should not theoretically develop hypoglycemia, which makes storage disorder here a bit less likely. Typically, we talk about 6 hours. So what age do you think they should present?
Usually they present after age of 6 months when the
6
feeding
months
becomes
when the feeding becomes
less frequent.
Now, after the glycogen will take care of you from around 6 hours to 18 hours. So if the fasting is beyond 12 to 18 hours, you will then have problems of gluconeogenic defect. At what age would they present with?
Beyond infancy.
So typically after 1 year. Fatty acid oxidation will not even present routinely. They will present when you are stressed out. Now, any of these conditions, if the feeding is less, they will present you with hypoglycemia. So this, I would say, if you think of a day 7 child with hypoglycemia, we're thinking of a milder potassium ATP channel defect. We're thinking of metabolic disorders like organic acidemia, galactosemia. I would not keep a glycogen storage disorder at a very high up in terms of the index, in terms of clinical parameters. Now let's go on examination. Which finding on examination are you specifically looking at?
For the hepatomegaly, whether it is present or not.
What does it tell you?
If it is present, it is more likely a case of it could be both ways. Could be hyperinsulinism as well as galactosemia as well as.
So it's not a discriminatory one.
Not discriminatory.
Which examination finding will give you a direct clue to diagnose?
But
That's not a history.
other than this, like eye examination could give us
For
galactosemia. There will be a cataract.
okay, good. Hepatomegaly can also happen in galactosemia. So that's not a. So when you talk about a sort of assessment, I'm talking about a highly sensitive, specific sort of a scenario. Anything will give you directly that this is hyperinsulinism and this will improve over time.
Sir, any features of any appendix?
Ear creases, omphalocele, macroglossia to indicate Beckwith-Wiedemann syndrome as a possibility. So that is something which we have to consider. So main things, of course, you will look at everything, but you're looking at cataract, you're looking at hepatomegaly, you're looking at hairy pinna, you're looking at features suggestive of a infant or diabetic mother-like picture, which will suggest you hyperinsulinism. Pointers of Beckwith-Wiedemann syndrome should be looked at. Of course, you have to look at everything. Pigmentation. Why cannot it be a defect of multiple pituitary hormone deficiency? So you can't exclude anything. You need to be open. So you have to look at the phallic size and everything, gonads, everything becomes important. So carry on.
So on examination, the child was lethargic when he presented to us, and he was responding poorly to the pain. The capillary refill time was less than 3 seconds. Pulse was a bit higher on 150 to 160 beats per minute, 100% saturation without oxygen. The height was 51 centimeter and weight was 3.06 kg and a head circumference of 36 centimeter. There was no micropenis. SPL was around 4.2 centimeter with TB1 and PH1. There is no dysmorphic features present, and there is no neurocutaneous marker till now we have got.
And you have to mention what midline defects.
Moving on to the next, like chest examination was normal. There was no cardiac defect. Any murmur or anything was present. On abdominal palpation, we found a hepatomegaly of 5 centimeter, which was below the right costal margin, which was firm in consistency with a irregular bit of border.
Now, if you talk about hepatomegaly, if you differentiate the different forms of hepatomegaly can happen in hyperinsulinism, in the setting of fatty acid oxidation defect, plus minus cholestasis because of galactosemia, definitely MPHD can also cause hepatomegaly. And of course, if you look at the glycogen storage disorder. So the texture, the size, what is the difference between these forms? So what is the, let's say, hepatomegaly in hyperinsulinism?
In hyperinsulinism, it will be a soft liver, border will be a regular border. It is not that big, it like 2 to 3 centimeter below the.
And it is caused by?
It is the glycogen deposition
So
in
it's
the
a glycogen storage. So hyperinsulinism is also a glycogen storage disorder. So anybody who has hepatomegaly in this age, I would not think directly of glycogen storage. I'll think more of possibility of a hyperinsulinism. Now, second is galactosemia. Hepatomegaly in galactosemia is?
Will be larger and will be hard on consistency.
More like a fibrotic, that sort of appearance will be there. And clinically, you will get icterus. You will get history of cholestasis. You will get cataract. So that will become important. So this is firm in consistency with irregular border. What about GSD? How is the hepatomegaly in GSD?
It will be large hepatomegaly.
Yeah. And soft or hard?
So
Generally soft. It will become hard. Which GSDs are more likely to cause hepatic dysfunction?
3, 6 and 9.
Where it's mainly the glucose is too much. So it is not going to happen. Cirrhosis is not going to happen at this stage. They present more likely to be a chronic liver disease differential. So this is a big liver. So we have to be cautious about that. Then firm consistency is a bit of a confusing picture. So galactosemia will become a possibility here that you have to consider. Carry on.
So in CNS examination, to rule out any hypoxic episode happened or not, the tone was normal. The anterior fontanelle was flat with pulsating, and the child was euthermic with there is no core to periphery gradient was present. And also there was no midline defect present. I have not mentioned here, but there was no midline defect like lip palate that was present.
And you have to mention about Beckwith-Wiedemann as an important possibility at this time. That can also have organomegaly. So that is important to remember. What is the cause of Beckwith-Wiedemann? Genetic basis?
oligogenic.
The barred brittle. Beckwith-Wiedemann is a?
LMP.
It is the same defect that you see in?
Russell Silver.
It's the opposite. So it's paternal versus maternal imprinting. Yeah. Carry on.
So till now the findings that we found, we just go for some disease in favor and disease against the favor. Sorry for the question here. So if the maybe is a term gestation, so the vascular causes like subarachnoid hemorrhage causing seizure or the benign neonatal convulsion or familial convulsions are be more likely. The disease against favor is the most important, that like preterm child with IVH or any.
So I think let's not discuss about causes of seizure at this stage too,
Yeah.
because that is beyond the discussion point. And of course, the examination is glucose is also part of examination.
Yes.
So let's not, because then you're differentiating a lot. Then there's no limit to discussing the causes, which is beyond our purview. So carry on.
So if we say the day 7 of presentation, Sir has mentioned most likely the KATP channel hyperinsulinism, a mild variety could be the
So
possibility.
let's go into the glucose and then we'll come back.
Okay, sir.
That's what
Let's move.
So then, because this doesn't make sense unless you know what the
Yes, sir.
thing, because if you talk about that A, B, C, D, you should always include glucose there.
So moving on to the investigation, the child has hemoglobin and normal hemoglobin creatinine level with a normal calcium and electrolyte. On presentation, the blood sugar was 41 milligram per DL, and according to the AAP and IAP guidelines, it is low.
What should be your cutoff for hypoglycemia? How do you define hypoglycemia?
Hypoglycemia is defined as in children, we don't use people's trial, rather we use from operational threshold to define that actually. So in case of like less than 4 hours child, the cutoff should be less than 25, 4 to 24 hours less than 35, 24 to 48 hours, it is 45 according to the AAP, and some guidelines says 50. And for 24 to 48 hours, it is like less than 60 is the operational cutoff.
Here you can think of the other way around. There are symptomatic features are there. So if he was not well, he was symptomatic, and sugar was less than 60, and you correct the glucose and he improves. That would clearly give you a definition of hypoglycemia. So in early neonatal period, you may be more this thing. But here, because symptomatic hypoglycemia is slightly different. But anyway, so 60 would be your operational threshold at this age. Yeah.
The blood ketone level was 2 millimole per liter.
So now so now I think is what the endocrine discussion will start off. You say you have a early onset hypoglycemia around day 7 of life, which is ketotic. So what do you think of the possible causes with hepatomegaly?
So the possible.
So what are the causes of hepatomegaly with hypoglycemia?
Hepatomegaly with hypoglycemia, the causes are, if we think about the neonatal cause,
Yeah.
the GSDs are less likely. But still it can present like.
No, what is more likely? You go by that.
More likely causes like multiple pituitary hormone deficiencies could present with hepatomegaly with A. And other causes like organic acidemias can also present with ketotic hypoglycemia.
Yeah. So first, if you look at the whole picture, we talked about hepatomegaly with hypoglycemia, hyperinsulinism, fatty acid oxidation defect, really, and galactosemia. Those three are out because your ketone is 2. At what level of ketone you will say that hyperinsulinism is out?
Sir, about 2.
Above 2. Okay, 0.6 also is less. So 0.6 to 2 is hypoketotic. So this is definite ketotic too. Any form of hyperinsulinism which is associated with ketosis, or it may develop ketosis. Hyperinsulinism. One form of hyperinsulinism can develop ketosis in special circumstances.
Exercise.
And that is very, very similar to another condition which causes mild diabetes.
GCK.
So what will happen? If you have an activating GCK, what will happen?
Activating GCK will body will sense that already glucose is.
Yes, so your curve will be shifted to the left. So threshold, the insulin glucose curve will be shifted to the left. So you will be producing more insulin for the level of glucose. But there will be a level beyond which insulin production will stop. Then you will develop ketosis. So in severe cases, even insulin excess conditions may also develop ketosis. The specific example is GCK. Otherwise, this is out. Galactosemia, can it cause ketosis? Okay, how? So when we talk about non-ketotic, we typically talk about either you have got too much insulin, which is inhibiting glucose production, or we talk about problem in insulin in ketone production like fatty acid oxidation defect, or we talk about galactosemia or fructose intolerance. They are hypoketotic or non-ketotic. So this goes against galactosemia. So now this is a very, very confusing picture. What are you thinking now? Ketosis with organomegaly with hypoglycemia.
And there was no signs of any multiple pituitary hormone deficiency still now in examination as well. So I think could be a severe form of GSD that presented earlier because of the feeding
Or
organic acidemia.
organic acidemia will be a strong possibility here. Carry on.
And the patient was done urine for reducing sugar, though ketone was high, it was came negative, and insulin was undetectable in this scenario. Cortisol level was high for the level of
Appropriate.
appropriate for the level of hypoglycemia. So if we go by our own algorithm, so this patient is developing ketone. So this is a ketotic one, so would need not go to the galactosemia or hyperinsulinism pathway. But sometimes fatty acid oxidation defect can present with hypoketotic pictures.
Mild ketotic, yeah.
And cortisol level was normal, so unlikely it is single hormone deficiency is causing hypoglycemia. And accelerated starvation in this age group is not really a common scenario. So the differential diagnosis is till now we have that fatty acid oxidation defect probably and any cause of severe glycogen storage disease or organic acidemia in this scenario.
So organic acidemia typically what age do they start? What age do they start to present?
It is present later on, like 5 years of age.
Organic acidemia.
Present
It presents at birth, as soon as the feed is started. So, but do they improve? So if you see organic acidemia, will they be fine for 4 or 5 days? So what is the usual presentation of organic acidemia? If they are sick, they will go to the ICU, and unless you stop something, so that becomes less likely. But yes, that is the most likely. Already day 7, so you can say, okay, it may progress further. Yeah.
So moving on to the further investigation that we have done, the SGPT and SGOT levels were high in this child. Lactate, the child was producing lactate 3.3 millimole per liter.
Now, what does lactate tell you?
Lactate is telling us that probably the curve is towards the right side. The pathway is towards the right way. That means it is less likely to be a cause of fatty acid oxidation defect.
No, what do you mean by right way?
The pathway is on the right.
Okay, no. What I am asking is, what does lactic acidosis in a child with hypoglycemia mean?
That means
which children with hypoglycemia develop lactic acidosis?
It could present like in sepsis, where the lactate levels are high due to the infection. It could present like in glycogen storage diseases, where lactate could be
which GSD?
GSD1.
So that's what I'm asking. So I'm asking what specific point of the defect will lactate go up. So what does lactate? How does lactate come into the glucose picture? We'll discuss about the pathophysiology a bit, but how does lactate? Lactate is accumulating because it's not getting converted to glucose. So which enzyme converts lactate to glucose? That's what I'm asking.
Glucose 6 phosphate.
Yeah, glucose 6 phosphatase is for everything, yes. But fructose 1,6 bisphosphatase is also involved. Yes. So only 2 conditions you will have: ketosis with lactic acidosis, this is GSD1, versus gluconeogenic defect, which is fructose 1,6 bisphosphatase. So lactate is very, very important here. Yeah.
We have found that there was a mild acidosis, almost 18 bicarbonate. Fasting lipid profile we have done to see that there was hypertriglyceridemia present in this child, and uric acid level was also high in this child.
So if you now look at this picture, your diagnosis is made.
Yes, sir.
What was found on CBC? Anything on CBC which can further classify your diagnosis?
Neutropenia.
Yes, so you should also look for what the CBC was saying. So now, how which diagnosis will explain everything?
So if we see that there was low sugar with ketotic hypoglycemia, the lactate level is high, there is hepatomegaly with hypertriglyceridemia and hyperuricemia. Most likely a case of GSD1, but still gluconeogenic defects also can produce a hyperuricemia.
What are the typical presentation of gluconeogenic defect?
It is usually present late, and it is usually present after ingestion of fructose.
And generally the acidosis is much more. Yes. They may actually present like decay, that sort of a ketoacidotic presentation. So this is classically, if you take off the age, I would say that this is clearly a case of GSD. There is no confusion based upon this. And one thing which can help you out, if there is neutropenia, you will get the classification of GSD1B. That will be likely there. which finding on examination will also help you reach a diagnosis of GSD1 in which case. So you have said that the liver is enlarged. Anything else you can palpate for, which will give you a more likely that this is GSD, especially in the setting of high uric acid. So your liver is enlarged. Anything else is enlarged?
Splenomegaly.
Yes. You will be able to get a ballotable mass. That will give you a clear-cut picture because glycogen is also stored in the kidneys. So that will be the one. You carry on.
So, so then we have almost reached the diagnosis by using the biochemical test. We just wanted to confirm whether it is a GSD1 or not, and we found that this is a homozygous mutation in the SLC37A4, which is probably GSD1B variant.
So what is unusual in this case?
First of all, the age of presentation was unusual because GSD is usually present after 6 months or something like that. But in severe cases, it can present a bit earlier. Second, there was no recurrent infections or any history was there. That is one. Yes.
I think some other issue, some other texture, something which I avoided in feeding. If you establish feeding, then of course you will not have hypoglycemia. But if you're not feeding, you will need glycogen, and that will be a issue from there. So high SGPT is a big clue. Which other condition causes high SGPT? Patient is absolutely fine. Suddenly comes to the emergency with seizures, headache, SGPT, abundance,
Liver,
which you will syndrome very, very bad. Sometimes it is associated with food of acid, acid
pancreas,
brain syndrome is basically I would say scenario that is carry on.
So the diagnosis is a 15 days old boy child presented with ketotic hypoglycemia, etiology being the GSD1B. So what are the management options? Dr. Nimisha will talk about the dietary portion about this, but the frequent nighttime feedings with nighttime snacks. Sometimes we require continuous nasogastric tubing, and right now the child is on the cornstarch diet, and he's not having any further episodes of hypoglycemia. But some other issues are there, like if there is high severe elevation of uric acid, some has advised to go for allopurinol in that scenario.
Why is uric acid high?
Uric acid is high because sir, the glucose 6 phosphate, which is not converting, it usually goes to the pentose pathway, and that causes.
And why is triglyceride so high?
Triglyceride is high because the pyruvate and alanine is not converted actually. So they are moving into the lipid formation.
Anything else?
They form acetyl CoA, and
What is happening to their cortisol, their growth hormone, these levels?
growth hormone.
They're persistently high. They are hypoglycemic. They have counter-regulatory excess.
Yeah.
They will also have features like Cushing syndrome. Their muscles will pick up. Yeah, so this is a very well-known phenomenon that is also contributing to many of these dysglycemia, metabolic syndrome. So it's a very, very bad disease if you don't correct it properly.
And there are some reports about the proximal renal tubular acidosis like picture and renal dysfunction subsequently, which has explained that a C inhibitor could be a preventer to further progression to the renal.
So basically the glycogen is stored there, so function is not there.
Dysfunction.
Yeah.
And
But hepatic dysfunction, is it very common or less common? SGPT here was very high.
very high, yes, sir.
So it is common, but hypoglycemia is the most predominant phenomenon. So if you are not able to treat hypoglycemia, they will have problems otherwise. While GSD 369, hypoglycemia is less likely. They present you with short stature, with myopathy, and there the liver may keep on accumulating and they may develop a chronic liver disease. So that is more dangerous from that perspective.
Just because hypoglycemia is severe, that is
so
the
it's
reason.
like, as I always say, hypocalcemia will also cause bleeding disorder. But by the time your coagulation factor profile goes down, the patient will die because of seizures, because of cardiac abnormality or anything. So here the patient will die because of hypoglycemia if you don't diagnose it. If you diagnose it, you can prevent that. Carry on. And yes, neutropenia is
Neutropenia
also.
is one of the important cause of GSD1B, so we should not miss the using GM-CSF in the children. And sometimes fibrates has been used for the lipid lowering in that
So
scenario.
out of this, the best strategy people have mentioned is continuous NG feeding at night,
Hmm.
especially that can take care of many of, see, most problems happen at night. See, that's the time when you're not eating. So that time your counter-regulatory hormones start kicking up. So this feeding has been found to be metabolically, it will stabilize the picture. Carry on.
So moving on to the follow-up, the child is now 1 year, 10-month-old child with maintaining blood sugar level above 70 most of the time. He is on constant diet and he's thriving well. But his developmental age is a bit delayed, like 9 months round, and there is no further episodes of hypoglycemia has been noted.
So I think this was a very good case. The key message here is that although we always say that we should not think of GSD in a very early childhood, sometimes there could be a problem in it. The key, when you talk about glucose homeostasis, we are basically looking at in terms of how the glucose comes in our diet, it is absorbed via the intestine, and then it is used predominantly via the brain, the muscle. These are the major usage organs as far as that. And then if you have extra amount of glucose, it is stored in the liver. So liver is like your bank where you store all your glucose in the form of glycogen. Now, this glucose can also be stored in the kidneys as glycogen, and it is then excreted there, which is prevented via the SGLT2, which we know all that. So, if there is a problem either at the level of feeding, problem at the level of glycogen storage or glycogen release, problems of glucose may be happening. Once you are fed and your glucose becomes more, it can be utilized via the brain, and then you will have this glycogen is providing you as a store in that perspective. So if you have problems in the glycogen synthesis or glycogen release, you will be if you have a problem in glycogen synthesis, of course you can't have enough glucose in the liver. So you will have, it's like somebody who doesn't have a bank account. When they eat, their sugars will become very high. And then when they starve, they will have no backup, they will become broke. So you will have fasting hypoglycemia and post meal hyperglycemia. That is your typical presentation of two conditions, GSD0, which is glycogen synthase deficiency, or GLUT defect, in which the glucose is not being transferred. If there is a problem in the glycogen release, what's happening? You have deposited your money in the bank and suddenly your ATM card is not working. So you have got a lot of money, but you cannot utilize it. You start using your alternate resources from that perspective. Now, kidneys can also produce glucose through gluconeogenic pathway, which is through fructose and other pathways. And when you have lost everything, the final reserve is, so if you have taken off all your bank account, you have sold all the ornaments, what is left? Property. You will sell the property. So fat is like your property, which the body uses as an alternate source. It burns the fat to produce ketones. So these are the defense mechanism. The first is whatever money you are making every day, that is surviving, that is like what you're eating. Second is you use your ATM to get food from the glycogen. Third is you're using all your money which you had stored in the form of some ornaments like gluconeogenic defect. And finally, you are selling your property to survive, which is your gluconeogenic, in which you're using your protein and fat to produce glucose. So that's the last thing the body wants from that regard. Now, we are mainly focusing about glycogen, so I'm not going to talk about other pathways, but remember, glucose is to be sent into the liver using GLUT2 and glycogen synthase and brancher. So glycogen synthase will add glucose to the glycogen, and they will be branched using the brancher enzyme. Now, this glycogen can then be really converted into glucose using debrancher, phosphorylase, and glucose 6 phosphatase. The most important enzyme of the carbohydrate metabolic pathway is the glucose 6 phosphatase, which is the common point for both the glycogenolytic pathway, the gluconeogenic pathway, the galactosemia pathway. All of them converge at the level of glucose 6 phosphatase to release glucose in that regard. Now, of course, pancreas produces insulin, which will try to store the glucose as glycogen. So it will increase the glycogen synthase and brancher activity, and it will inhibit the debrancher activity, which will release, so it will cause storage of glycogen. That is why hyperinsulinism, you will have hepatomegaly because of glycogen storage. Glucagon has got a lot of effects, but the major effect of glucagon is glycogenolysis. So it is going to release your glucose from that perspective and produce more glucose. Now, glycogenolysis is a process in which glycogen is broken down into glucose. The three major organs where glycogen is stored is the liver, the kidneys, as well as the muscles where it will be stored. It is converted via phosphorylase and phosphokinase to limit dextrin. What do you mean by limit dextrin? It is the point at which the branch comes. Once the branch comes, they cannot convert glucose. From the limit dextrin, you need debrancher enzyme, which produces glucose 6-phosphate, which is converted via glucose 6-phosphatase into glucose. So if you have a problem in the glucose 6-phosphatase, nothing will be produced. If you have a problem in the debrancher, you will have some production, but then after a time, you will not be able to produce glucose. If you have a problem in phosphorylase, phosphokinase, it will be even more. So the gap between feed and hypoglycemia will be the maximum for phosphorylase, phosphokinase, followed by debrancher, followed by glucose 6-phosphatase. So those conditions present more as a storage disorder, as hepatomegaly, liver dysfunction, and problems of myopathy, pain, exercise-induced problems, and all those things will be more likely. Now, as I said, glucose 6-phosphate is a common site. It is also being produced via the fructose 1,6-bisphosphatase. All the gluconeogenic pathway will also converge out there. It's like a confluence. So this is basically coming from lactate to pyruvate, which is then getting converted into glucose 6-phosphate. So now what I was talking about, if you have a problem in glucose 6-phosphatase, you will have a back effect. If you have a problem in fructose 1,6-bisphosphatase, you will have a back effect towards lactate. So only two conditions lactate will go up. In debrancher problem or phosphorylase phosphokinase, which is GSD 3, 6, and 9. This is what we talk about as milder forms of GSD. You will not have high lactate because lactate is not in their path. So this becomes important to understand. Now, galactose is converted to galactose 1-phosphate and then again via the same. So it's like a three confluence, Triveni sort of a scenario. All three are getting mixed up here. And the most important point there is glucose 6-phosphatase. So if you have no glucose 6-phosphatase, there is no way your body is going to get glucose. You need to feed every 2 hourly. That is the big message from that perspective. So this provides backup in infants for 4 hours. So when I say 4 hours, that infant may not have fed for 4 hours, and that's why hypoglycemia happens. And then somebody is not feeding enough, you may present early. That's less likely, but it can. In childhood, it will be 6 to 12 hours, and then the issues would be there. Now, the second backup, which we are talking to discuss about, the second condition which you presented is gluconeogenic defect, which means production of glucose from alternate sources. So this is the last ditch effort. Everything is gone. You are selling your home to get the glucose. So your building blocks of the body are amino acids. You're breaking amino acids. So lactate and alanine are converted to pyruvate, which is converted via carboxylase to oxaloacetate, then pep carboxykinase to pep, and then fructose 1,6-bisphosphatase to, again, you get fructose 1-phosphate, and from there you get the glucose 6-phosphatase, which is working from that perspective. The fructose 1,6-bisphosphatase is also important because it is also the point where your fructose and glycerol come into the picture. So here you are linking your fatty acid oxidation, you're also linking your fructose to produce glucose. That is why Alapan was talking about that you should not give too much fructose. If you give them too much fructose, what is going to happen? You will have accumulation of other things, but not production of glucose. This is something important in this particular effect. And then finally, you have got glucose 6-phosphate, which is converted into glucose. Now, fructose 1,6-bisphosphatase is the most severe form of gluconeogenic defects. There are other forms also like pep carboxykinase or carboxylase, which are milder. They will not have that many features and they will have milder lactate elevation. But yes, they can have, but they typically will present with other features. Gluconeogenesis provides backup for 12 to 24 hours in that perspective. Now, which hormone regulates which becomes important to understand. Insulin is a hypoglycemic hormone. So it will decrease glycogenolysis, decrease gluconeogenesis, lipolysis, and ketogenesis, everything. Your glucose will come down. In fact, it will promote your glycogenesis, it will promote your ketogenesis, it will promote your fat formation, and other things will be there. Epinephrine has got a major effect on glycogenolysis and ketogenesis with milder effects on other perspectives. Glucagon mainly works in the setting of glycogenolysis as well as gluconeogenesis, and growth hormone will clearly have a major effect on lipolysis. That is why individuals who have growth hormone deficiency look chubby or fatty in that perspective. And cortisol has a major effect on gluconeogenesis. But so there are four hormones which are regulating the counter-regulatory process. There is overlap. You can't just say that it's only that, but predominantly you can say that glycogenolysis is a glucagon phenomena, lipolysis is the growth hormone phenomena, gluconeogenesis is the cortisol phenomena from that perspective. So anybody who is fasting should have a glucose which is less than 50 milligram per DL. Insulin should become undetectable. Cortisol level should be above 550. Growth hormone should be more than 10. But sometimes these counter-regulatory, if they are long-term deficient, may not be that low. So then you can have some exhaustion which may happen from that perspective. Now, other scenario would be your glucagon should be high. So giving extra glucagon should not increase your level of glucose with the exception of hyperinsulinism. So that is something to remember. Glycogen problem happens at 6 to 10 hours. Gluconeogenic pathway problems happen at 10 to 24 hours. And then subsequently, other parameters will be ketotic pathway will be 12 to 24 hours, which will give you a picture. If you give glucagon, there will be no increase in glucose. If you in fact have a glucose 6-phosphatase defect, the lactate will increase in a fed state. So glucagon test is a way to differentiate gluconeogenic defect from fructose 1,6-bisphosphatase deficiency in that regards. So all processes are important. At 6 hours, you can see 90% is glycogenolysis. As you go from 12 to 24 hours, 24 hours, the glycogenolysis becomes less. The other pathways become important. So timing and gap between meal becomes a very, very important process to understand from that perspective. So we'll go one by one. So glucose 6-phosphatase defect, the problem is at the confluence of all the three pathways. So you will have no glucose production. Glycogen is going to be stored in the liver. Fructose is not working. Galactose is not working. So glucose is not going to increase from that regard. More glycogen will basically mean it will be accumulated in the liver and in the kidney, causing hepatomegaly and renomegaly. You will have high level of cortisol, epinephrine, growth hormone. All the counter-regulatory hormone will be more. Ketosis will be there because you will produce ketone. Triglyceride will go up because of all these counter-regulatory hormones. Uric acid will go up because of the action through that pathway which becomes activated. So you will have hypertriglyceridemia and high uric acid which is there. Glucose level will not increase after giving glucagon. You will in fact have a paradoxical rise in lactate which will happen with glucagon injection. The GSD basically is two types. GSD1, which is basically a defect in glucose 6-phosphatase with defective glycogenolysis, defective gluconeogenesis, presenting onset is 4 to 6 months with hepatorenal, high lactate, ketone, and glucagon. GST1, 1B is actually a problem in the glucose 6-phosphatase transporter. So the enzyme is not defective, the transporter is defective. And in this scenario, the problem is similar to GSD1 with the exception of leukocyte dysfunction. So this case which Alapan discussed has a GSD1B which is there. The manifestation again is later, but you may have an earlier presentation. There is a greater predisposition to autoimmune disorders and infections in that regards. Now in debrancher activity, GSD3, you will have some production of glucose, but after the branch comes in, you will not be able to produce. You will have accumulation of limit dextrin. It has a delayed onset with hepatic dysfunction. This is a major presentation which will happen. And there will be myopathy because muscles also need a lot of glycogen to provide us with the energy levels in that regards. So GSD6 and 9, they have a problem in phosphorylase kinase, which is a terminal defect. Manifestation is late with growth failure and myopathy. I have seen patients with these forms of GSD referred mistakenly as growth hormone deficiency because they'll be short, they'll be plump, They will be chubby, and that's why they are labeled as GSD. But in fact, they will have huge liver, and you can identify that in that regards. What is GSD zero, Dr. Sandeep?
The GSD zero is due to glycogen synthase defect.
Okay, yeah. What
Uh,
happens there?
In this, there will be no production of glycogen in the liver, and there will be a deficiency of glycogen, so there will be no hepatomegaly.
So, is
And
this really a GSD?
this is basically not a GSD; it's a misnomer.
So, in a classical sense, it's not a GSD, but it's a problem in glycogen metabolism. So, classically, as you said, the problem is in glycogen synthase. Synthesis does not happen. You will have fasting hypoglycemia. You don't have any bank account. So, when you need, you will not get the money. But whenever you get your salary, everything is overflow. So, you have post meal hyperglycemia. So, this is a paradoxical response which happens in the setting of a hypoglycemia followed by hyperglycemia. And this is a close differential of ketotic hypoglycemia. In fact, the recommendations are if you're labeling somebody as ketotic hypoglycemia, you in that scenario give them glucose and see if they become hyperglycemic. That is important to remember. Now, GLUT2 or Fanconi-Bickel syndrome is again an important scenario in which you will have a problem in the renal and hepatic transport. You will again behave like GSD 0. So again, 6-month onset fasting hypoglycemia, post-meal hyperglycemia. We have seen patients who are presented more with renal abnormalities in the form of Fanconi syndrome like that, but they can also have hypoglycemia, which is their RTA and glycosuria. Finally, the gluconeogenic defect, the problem is at the fructose 1,6 bisphosphatase or of course pepcarboxykinase and carboxylase. Here, you will have no production of glucose which is happening through the alternate pathway, so it will be later onset, typically after 1 year. So this case presented 16 months. This is the typical presentation which is happening. Your lactate will be high in fructose 1,6 bisphosphate deficiency, and you will have ketone which will be present. There will also be no increase in lactate after glucagon. So why do you think this happens? How is it different from GSD1 then? Why increase?
Why lactate is not high?
Yeah.
Uh, because in gluconeogenic defect, if there is no accumulation of the lactate in the previous part. So
You have accumulation of lactate.
but it is a little amount than
So compared to GSD1, you will have much more amount there in GSD1. Here it will be much lower. But of course, lactate is high in the basal state, but fed state giving glucagon does not increase. The fructose 1,6 bisphosphatase deficiency, the defect is onset after 12 months with high lactate and acidosis. It's a life-threatening condition. So if you now summarize the condition, enzyme defects, of course, GSD1 is glucose 6 phosphatase with massive hepatomegaly. You will have high levels of lactate onset at 6 months and they will develop hepatic adenoma. GSD3 is a problem of debrancher. GSD6 or 9 is phosphorylase or phosphorylase kinase, large liver. But their lactate will be normal. Onset is typically 12 months and you will have myopathy and transaminitis as a major presentation. GSD0 will have no hepatomegaly and they will have hypoglycemia, which is basically having prandial hyperglycemia. Gluconeogenic defect is fructose 1,6 bisphosphatase, where you have massive hepatomegaly with high lactate after 1 year. That is the diagnostic feature. So identifying this glycogen storage disorder is very important because it's not just about glucose. They have so many other metabolic defects. They have got dyslipidemia, they have got liver dysfunction, renal dysfunction, RTA, muscle problems. So this can be a big problem, and all you can do, if you give them periodic glucose, you will improve. Now that is
As we all know, GSD is a genetic metabolic disorder of liver with defective glycogenolysis and gluconeogenesis both in GSD type 1, defective glycogenolysis but intact gluconeogenesis in GSD type 3, 6, and 9, and defective storage of glycogen or glycogen formation in GSD 0. There is also defective enzyme which converts galactose or fructose to glucose, and they are converted to unwanted glycogen stores like lactic acid, fatty acids, uric acid, which is harmful, and therefore there is risk of hypoglycemia during the periods of fasting. There are two types of carbohydrates: complex carbohydrates, which takes longer time to digest, like bread, cereals, grains, rice, pasta. Simple carbohydrates, which digest easily, like glucose, galactose, lactose, fructose. Therefore, our diet should include more of complex carbohydrate and it should be less than 5 grams of simple sugar. Total fat intake should be 20%.
Why do you want to restrict the amount of simple sugars?
So because of in postprandial hyperglycemia immediately after
So what will it cause? You may have hyperinsulinism.
insulinism.
You don't want that to happen. So if your body is having low sugar, so insulin is adjusted in that regard. If your sugars goes even slightly up, you will have immediate hyperinsulinism. Something like when you treat hypophosphatemic rickets, if you give too much phosphorus at one time, what happens?
If we give too much phosphorus in hypophosphatic rickets, the phosphate will inhibit
The phosphorus goes up,
phosphorus goes up. So
PTH comes in,
pH will be increased.
it will wash it out.
Okay, it will
So here, if you give too much simple sugar, you'll have hyperinsulinism, which is going to wash off your hypoglycemia. So that's why this is important. In this point, you want something like a slowly releasing. So if you can get a depot preparation of glucoside sort of a thing, that will be a better phenomena in that regard. So you say just go back. This is the most important point. So you're saying bread, cereal, grain, rice, and pasta. But usually they will not have enough to sustain. So problem happens at night. It's not that the daytime they will can feed 4 hourly. That's not a big problem. But night is the major problem. So, but these things, do you think they will take care till 12 hours? So often patients with diabetes say in the night my sugar when I say it was 120, morning also it was 130. So despite taking insulin, so how did that sugar go up?
Because of hepatic release of
So hepatic glucose production is a major thing. How much does the liver produce every milligram per kg per minute? Do you think?
4 to 6.
4 to 6. So this is such amount. So 4 to 6 milligram per kg per minute. If you translate that, now this is how you can work out is how much grams you will need per day. That is the amount of, and particularly in that 12 hours, because that's very, very crucial. So that your bread, cereal, grain, pasta may not be able to do that. So of course, delaying your feed will become important. Incorporating them may be important. How else you can increase their duration of action? So for the same carb, how can you prolong the duration of action is by decreasing the glycemic index. How do you decrease the glycemic index? If you take only a bread or if you take a fried bread,
Right.
fried bread will be longer acting. If you have cheese on that, it will be longer acting. So adding protein and fat may prolong that. So that is something also which is there. So taking a milk sort of a scenario may be better. Giving a glucose will be very hazardous because that will have very high, low, very high, very low. That is something which is avoided. So carry on.
Fat requirement is 20% of total daily calories with equal distribution between monosaturated, polyunsaturated, and saturated fats. Cholesterol intake should be less than 300 milligram
So
per.
again, this is a sort of a double-edged sword. Your triglyceride is very high, so you don't want to give too much triglyceride. But still, if you don't give fat, your glycemic index may become very high. So this is something which is there. So we will counter that with the next part, protein.
The goal in GSD is to maintain normal glycemic state in between meals. So we can have cornstarch. In infants, there is a limited amount of pancreatic amylase production, which helps in digestion of uncooked cornstarch. Therefore, in infants, it is preferred in daytime to have frequent feeds, and in night, nasogastric tube feeding is preferred using enteral formula or glucose polymers. In more than 1 year, we can use raw cornstarch with a dose in children less than 2 years being 1.6 gram per kg every 4 hourly, and more than 2 years with 1.75 to 2.5 grams per kg every 6 hourly.
How do you get this cornstarch?
So there is a available pack.
So it's easily available. It's basically like it's used for various preparation. So it's not available as cornstarch. It's available as corn flour. Corn flour. It is available as corn flour in the market. If you go to the supermarket or the grocery store, they'll give you corn flour, which is available. So this is very, very important. NG feeding is the treatment of choice. It is like your continuous pump sort of a scenario, but that is not easy to identify. So this becomes like your land test. So you can say cornstarch is like a long-acting insulin, while that is like an infusion of insulin. So that is a better way. But then having an NG feed continuously monitored and you don't have any aspiration, all those issues have to be considered.
Therefore, the allowed sugars are glucose, dextrose, dextrin, maltose, corn syrup, aspartame, acesulfame K. Sugars that are not allowed or are limited in to be consumed in limited amount is fructose, galactose, brown sugar, sucrose, maple syrup, or raw processed sugar.
So we already discussed that fructose really comes through the different pathway. And the other thing about fructose is, what does fructose do to insulin?
Inhibit increases.
It's a more potent stimulus of insulin than glucose. So fructose is something you won't want to give too much. That can cause more problems in terms of insulin release.
Fructose and galactose should be less than 2.5 gram per meal. Uh,
Yes.
Fruits contain fructose, should be consumed in moderate amount. Milk and milk products contain lactose, should be used in limited amount. We can use unsweetened soy milk, and since the consumption of milk and milk product is limited, we have to supplement child with calcium and vitamin D. Sugary drinks should be avoided. Sugar-free tea, sugar-free drinks can be taken. Artificial sweetener have sorbitol; they should be avoided as they get converted to fructose. In GST1, the main role is of raw cornstarch. It acts by hydrolysis and digestive tract and releases glucose molecule. It is slowly digested in other complex carbohydrates, provides 30 to 45% of daily calories, prepared by dissolving in lukewarm water and shaking the container well. It should be mixed with fluid just prior taking it. Should not be mixed with spoon, as the cornstarch will stick to the spoon and child will not receive the correct dose. It should not be heated or cooked because it will break down. And meal should be consumed prior to taking cornstarch because it will make child feel full. Because the duration of action of cornstarch is 4 hours and it requires at least one feeding in the middle of the night, the extended release cornstarch was developed. Using structural modification was done. Waxy maize starch known as glyphosate with duration of action of 7 to 10 hours. It advantages was that middle of night feeding was omitted and there was improved sleep and quality of life. Disadvantages being a strong taste of corn and increased abdominal pain, flatulence, and diarrhea. In GSD 3, 3A is inability of liver and muscle to break down glycogen to glucose, and 3B is inability of liver to break down glycogen to glucose. The lack of glycogen access in muscle leads to muscle damage. Therefore, a high protein diet with low carbohydrate diet, like modified Atkins diet, is preferred in GSD 3 with protein requirement being 3 to 4 grams per kg per day. Advantages, it has been seen in various studies that it improves cardiomyopathy and avoid tissue deposition of abnormal glycogen. In GSD 2 and 4, there's no specific diet available. GSD 5, simple carbohydrates can be used. GSD 6, frequent carbohydrate meals or cornstarch to be used. And GSD 7, low carbohydrate ketogenic diet can be used. The monitoring of blood glucose and ketone is essential to determine the optimal balance of protein and cornstarch in patients.
You can all go and have a look at our app, which also has a hypoglycemia interpreter, which will help you reach the diagnosis, our courses, as well as our platform.